We'll have the next presentation by Dr. Anirudh, where he'll be discussing about learning lessons in surgical management of retinal angiomas.
This presentation discusses the management of a patient with bilateral multiple retinal capillary hemangiomas, highlighting several nuances and learning lessons. Our patient is a 29-year-old Asian Indian girl who presented with sudden decrease in vision in the right eye. Examination revealed visual acuity of hand motions close to face and a combined retinal detachment with a tractional fold involving the macula extending inferotemporally and several retinal capillary hemangiomas in the right eye. The left eye showed a large inferior hemangioma with a feeder and a corresponding draining vessel. Given the clinical presentation, it is essential to perform a thorough systemic workup prior to any surgical decision making. Our patient underwent blood pressure monitoring, measurement of urinary vinyl mandelic acid levels, and imaging, which revealed cerebellar hemangioblastomas and pancreatic cysts. Our first learning lesson is that in the presence of underlying systemic lesions, especially pheochromocytoma, any surgical intervention can be catastrophic. Another important aspect in the management is screening of family members. Ultra-wide field imaging of a brother revealed small retinal angiomas. Remember, family screening could be life-saving. Due to positive family history and systemic lesions, our patient was diagnosed with von Hippel-Lindau-related retinal angiomas based on the Danish and international criteria. In these cases, various surgical complications have been described, including intraoperative bleeding, postoperative epiretinal membranes, and recurrent angiomas, among others. In view of combined retinal detachment involving the macula, we decided to proceed with pars plana vitrectomy in this case. We performed the surgery under local anesthesia, as these cases usually do not need hypotensive general anesthesia. The recti were bridled and a 240 band was passed 360 degrees. We also applied 277 tire in the inferotemporal quadrant to support the peripheral retina. Following the application of scleral buckle, standard 25 gauge pars plana vitrectomy was initiated. The retina was inspected and core vitrectomy was performed. A large raised retinal angioma was located superiorly. The vitrector was used to gently separate the vitreous adhesions from the angioma. Another angioma was located inferiorly. These angiomas can bleed a lot, making it a very challenging situation. Remember to be very careful and precise with the cutter, or else you could end up causing catastrophic damage. Slowly but surely, the angioma was excised with the cutter and endodiathermy was applied. An important lesson is to keep endodiathermy ready, since these cases can have torrential bleeding obscuring the surgical view. Perfluorocarbon liquids may also be kept standby. There were other angiomas in the superior retina. The vitreous connections between them were carefully removed. The feeder vessels at the base of each angioma were cauterized. The diathermy needs to be applied several times to ensure complete hemostasis. Peripheral vitreous-based shaving was initiated before tackling the retinal fold and the inferotemporal angioma. Triamcinolone was used to stain the vitreous membranes so that the retinal fold could be dissected. An important lesson is that eyes with hemangiomas commonly develop epiretinal proliferation, which needs meticulous dissection. Tano's diamond-dusted scraper and internal limiting membrane forceps were used to remove these membranes to relieve all the traction. We decided to perform inferotemporal retinectomy. Prior to retinectomy, perfluorocarbon liquid was injected to prevent the possible accumulation of submacular hemorrhage. Endodiathermy was used to mark the area of dissection. Retinectomy was carefully performed. The large orange angioma can be seen inferotemporally. Perfluorocarbon liquid was used to flatten the retina once all the traction was relieved. Laser photocoagulation was applied all around the area of retinectomy. Finally, the perfluorocarbon liquid was exchanged with air and silicone oil was injected for internal tamponade. Post-operatively, visual acuity was counting fingers at 3 meters. The retina was flat and the area of retinectomy was well supported on the 277 tire. OCT showed a flat macula.
It's the one and only Digo Double G. You know what happened with it.
To conclude, although VHL-related angiomas requiring surgical intervention are rare, meticulous preoperative ocular and systemic workup and careful surgical planning may help in improving visual outcomes. Thank you. This
Uh, very interesting case and very nicely managed by Dr. Anirudh. I would call upon Dr. Divyansh Mishra if he can come on the dais, and Dr. Bhavik Panchal if he can please come and join us on the dais. And your take on this, Dr. Chitranjan. In the meantime, we need to call upon Dr. Divakant Mishra for the next presentation. Dr. Devakant would be presenting a very interesting case on a surgical approach of a case in, in intraocular cysticercosis. So, Dr. Divyansh, what would you want to speak about the previous case?
Very nice surgery shown by Anirudh. Fast, fast, fast. Interestingly, I would not want to do any RR in cases wherever angioma is there, because the only issue is that whatever angiomas which we are seeing right now, because we are expecting to have more angiomas which may occur at other areas in the retina also later on, and these cases over a period of time develop very significant AHF proliferation, and they may have even a vascular AHF proliferation. So my take on this would be to avoid RR or a retinectomy as much as possible, and try to manage a case if it's possible with a buckle or an additional encerclage with a band, or having a very high indent. But RR would be my last and the final option, because beyond this, the survival of the eye would be very, very less. And as we can see, even after the surgery, also the visual improvement is very less. So, and these patients have bilateral involvement because of the VHL association. So, such cases, ideal would be to avoid any aggressive surgeries and try to do a stage-wise procedure, like try first a buccal band, and then if it doesn't help, then probably try to remove an ERM later on, and try to manage with laser. If the larger angiomas are there, you can use even brachytherapy, but the availability is a big issue in that. In India right now, the BARC is working very hard, and then whatever BARC plaques are there, those are very cheap plaques as compared to the foreign plaques which we had before. So it would also help in such cases.